You're listening to The Q Switch with your host, Spence.
Welcome one and all to the Q Switch Conversations podcast. I'm your host, Spence. And the mission of this show is to tackle subjects currently impacting ophthalmology, and we pull in leading eye care professionals and industry players to discuss their unique perspectives. So let's get into it. The title of today's episode is OD Life in 2025, the expanding role of optometrists in today's ophthalmology. What most people think about when they think of optometrists is they picture glasses, contact lenses, maybe a routine eye exam. But in 2025, the role of ODs is broader, deeper, and more collaborative than ever before. And my guest today is the perfect example of that. Dr. Elise Kramer is the founder of the Miami Contact Lens Institute and the Weston Contact Lens Institute in Aventura and Weston, Florida, respectively. She completed an ocular disease internship, a residency at the world-renowned Bascom Palmer Eye Institute, and a scleral lens fellowship, all with a focus on ocular surface disease. Her practice is unique in that she dedicates herself to restoring quality of vision and comfort for patients dealing with keratoconus, post-surgical complications, corneal implants, trauma, chronic eye disease, and more. Dr. Kramer, I'm thrilled to have you on with us today. Welcome to the Q-Switch Conversation.
Thank you so much for having me. I'm super excited to be here as well. And thank you for such a kind introduction.
Good. Well, you certainly earned it. So let's start at the beginning. You've had such a unique path. Bascom Palmer residency, fellowship, and now leading your own institute. What first inspired you to choose optometry, and why did you decide to specialize so deeply in ocular surface disease?
So I actually always wanted to be a physician, but I really wasn't that interested in doing surgery. And when I was finishing up college, my mom actually developed a tumor behind her eye, and it's called a schwannoma. It's a benign tumor, but she woke up kind of seeing double and was dealing with that. And they, at that time, the only option was really surgical removal, which could cause like the damage to the optic nerve, which would mean she would lose her vision. So she was like looking around and finally found an oncologist to do like a radiotherapy treatment. And that really shrunk the size of the tumor. She still wears prism for double vision. But long story short, like it really just sparked my interest in eye care. I was going with her to a lot of her like oncology appointments, and just seeing her dealing with that really opened my eyes, not trying to create a pun here, but to the eye care world. And I applied to optometry, just not knowing anything about it. And here I am. So it was something that I was interested in, didn't know much about, but then when I fell into it, I really began to love it.
Well, that's a very powerful story with your mom, and you had a personal encounter with an eye disease or an eye condition that really was somebody who you love. So at what age did that happen to your mom, where it really was your first encounter and exposure to, conditions and treatments of the eye?
So good question. So I actually started optometry at the age of 17.
Okay.
We start really early in Montreal because the track is very different. So we actually graduate high school grade 11, and then we have like 2 years of what's called college, which is CEGEP. And then from there, if you have high enough grades, you can get directly into medicine, law, optometry, pharmacy, dentistry. So I was 17. So this happened when I was like 15, 16. And then, I was applying to this program. And yeah, so this was my first exposure was at that age, but I've been exposed to medicine forever. My dad is a pediatrician and retired now, but he was very much involved in that industry and working at the Children's Hospital, et cetera. So I've always been exposed to medicine.
Okay. So it's kind of in the family. So, well, I would say that it seems like that foundation really set the stage for your career. But of course, optometry itself has gone through major changes. Over the last decade, how have you seen the role of optometrists evolve in the delivery of eye care, and what has it meant for patients?
So I think that there's more and more of a need for optometrists to specialize. There's always going to be the importance of refracting and screening for disease, but I really think optometrists need to go more and more into specialty care because there is a need for it. I think ophthalmologists are amazing at what they do. There are not very many of them, and there's a lot of areas, maybe Miami is not one of them, but there's a lot of areas around the world and in the US that need more eye care, and where optometrists need to branch out of just refracting and diagnosing like mild disease to really being a little bit more interventional in terms of like dry eye treatments and, specialty contact lenses, low vision treatments, binocular vision, vision therapy, different things like that. And I think, we're leaning more and more toward that. And now, with so many platforms that can literally refract and give so much information about eye care, like AI based, I think, a lot of the things that we started off doing, just basic refraction, are now like super replaceable. And selling
Hmm.
glasses, I mean, you can find glasses everywhere now. So I think it's important to branch out of that and also meet the need of patients by doing different things that both make optometrists stand out, but also meet the needs around the world of
Hmm.
patients who are suffering.
And so, along with that evolution, the relationship between ODs and ophthalmologists has also shifted. How has the OD ophthalmologist relationship changed in terms of co-management, and what does successful collaboration look like in your experience?
So we're really blessed here in Florida. We have such a tight community of
Hmm.
ophthalmology and optometry. I would say for the most part, we're like great friends. We don't really see like much of I would say, political difference. It's like we all get along, but we all know what our role is in terms of patient care. Like there are so many ophthalmologists I can just text or call, ask questions, and send patients back and forth to. And I think, at one point there was a fear of like either looking bad for referring or, losing a patient by referring. But I think that as you build those connections with ophthalmologists and optometrists, like you also build the trust that that patient is going to come back in your chair if it's appropriate. And also that they're going to be in really good hands as well. So I think that, there may have been some tension before where, you know, maybe we were starting to get more right and it was like maybe stepping on a few toes. But I think now, ophthalmologists are really able to focus on the more invasive procedures. And we're able to do that peripheral care, which is what I think is the right thing. And we're able to, again, meet the needs of patients that are having issues, get them into surgical care more quickly if they need it, and also having peripheral care more quickly. So
Hmm.
co-management has become like a daily part of what I do. And I'm really grateful again for the network that we have here in South Florida.
So I can say from my vantage point as an industry person, and I've been in ophthalmology and eye care since 2011. And way back then, if I can say that, um, there were only a few practices that had like a true like wide ranging large geography of a OD network, and it was a referral network, and it would just be a referral back and forth. I think that's evolved to more of a co-management where you truly are providing not just a referral to get them, to refer over patient for surgery, but also to work together in that patient's pre and post-operative care, and where, like you said, the peripheral support for that patient really lands on the OD these days, where before it was just a referral. It means a lot more. There's a lot more weight and there's more value there. And I think it's a more meaningful relationship. Would you agree?
I think so. And I think, the surgeon's best role is going to be in the OR. And so the less time that they could be in clinic is better because then they could help more patients, get them into
Hmm.
surgery sooner, get them into procedure sooner. And, we are so experienced now with treating, disease at various stages that we can handle the post-ops and the pre-ops and we can do all of that stuff. And that really
Hmm.
unties their hands and allows them to have more freedom to do more invasive procedures more often and sooner.
Sure, sure. So, well, speaking of collaboration, your practice philosophy seems to bridge both clinical expertise and compassion. You describe your work as restoring quality of vision and comfort. What does that philosophy mean to you, and how do you bring it to life in your clinic every day?
So I have a very kind of referral based practice actually because I'm
Hmm.
doing a lot of specialty lenses.
Right.
I focus a lot on dry eye. So I see a lot of patients that maybe other optometrists don't have the time or resources or desire to help because they're, busy. They have so many patients every day. I have a lower volume, but I'm able to spend more time with more patients. And I have also a lot of advanced equipment and treatments available so I can help these patients. So like I said, when you have a specialty lens practice, it's going to be a little bit lower volume so that you can allow yourself to spend more time with each patient. So I get a lot of referrals here, and just the change I'm able to make in these people's lives is so beautiful, and it really makes coming to work worthwhile every day. Just taking these people from 2400 to 2020 sometimes, just with a piece of plastic, with a scleral lens, is really, really meaningful. People get so emotional, so happy, and a lot of the time they had no idea what they could do to see again. Like they were ready to just get a transplant or, get some other sort of procedure to try to see better. And just being able to restore that vision is really what makes it just amazing experience. Every day we get to change lives, and it's really meaningful.
That's got to be an ongoing gratification to be able to, as a provider, be able to get those outcomes on such a regular basis. I mean, it means you're really doing good, and all the training, everything you invest, pays off every day in those really positive stories and those outcomes.
Absolutely. No, it's definitely meaningful.
And a big part of that mission centers around ocular surface disease, which so many patients struggle with. What are the most common ocular surface conditions you encounter, and how do you start building a treatment plan for those patients early on?
Great question. And it's funny because when I started fitting specialty lenses, I was like, this is what I do. This is my specialty. But I quickly realized that I would not be successful with specialty contact lenses if I didn't also treat ocular surface disease. Because when you have inflammation on the ocular surface, there's no foreign body that's going to thrive in there, especially a contact lens. And to be successful, for patients to be happy with their contacts, you really have to mitigate that inflammation. I don't have a formula that works for everyone. I think everyone is so different. And it's
Hmm.
really trying to figure out what the underlying cause is of the dry eye. So, what is going on? Is it more evaporative? Is it more mixed? Is it aqueous deficient? Is it allergy that's triggering this? Is it Demodex blepharitis? Is it, so just trying to figure out what each person has and tailoring the treatment to that patient would really change the outcome. Because honestly, if you just throw a steroid on everything, it's going to feel better, but it doesn't get to the underlying cause. Same thing with artificial tears. I mean, we used to think like dry eye, artificial tears, done. But no, there are so many nuances. We really have to dig sometimes and figure out what's going on. Is it hormonal, perimenopausal? Is it autoimmune related? There's so many different things. And again, to be successful with contact lens or even any surgical procedure, really have to treat underlying and subclinical inflammation.
Hmm.
So
So once you've made that diagnosis, the next question is always, what tools are most effective? So among the therapies and devices available today, which pharmacological treatments or technologies have really proven themselves in your practice?
that's a great question. So Xdemvy, which is the only FDA approved treatment for Demodex blepharitis, has been amazing because so many patients.
Say that again. What's it called?
It's called Xdemvy. It's lotilaner.
Xdemvy. Okay.
Lotilaner. It's a drop. I actually have a sample right here,
Huh.
so you can see it.
Okay.
And basically, that's a treatment for Demodex blepharitis, which is actually in 58% of patients. So most patients have Demodex, and a lot of the time, if you treat that alone, they feel so much better. And it
Huh.
can lead to so much inflammation and damage on the ocular surface. So that's one thing that I love. That's a pharmacological treatment that I really, really use very frequently. But there's so many new ones. There's the advent of perfluorohexyloctane, acoltramon, Tyrvaya. There's so many different treatments that we can use, which are great and give us a lot of options for patients. And then I would say device-based, I'm really loving IPL. I think
Hmm.
intense pulse light is a great way to mitigate inflammation that leads to meibomian gland dysfunction. And it works really well. And I really think that this is the one device where people really feel a difference. And there's also aesthetic benefits. So it has a dual purpose, and patients are really loving that. I'm really seeing improvement from IPL.
And IPL is laser that, what is it, dry? I've heard IPL in OD circles and folks who support from an industry standpoint, optometrists, and they talk IPL into laser. And of course, my company
Yeah.
does laser is obviously different, but what is the IPL exactly for those who are tuning in and may not be familiar?
Yeah. So IPL is intense pulse light. It is the only FDA approved lasered, I would say, for dry eye or meibomian gland dysfunction. The FDA approved one is called OptiLight by Luminous, and it is a device that reduces inflammation. It targets telangiectasia. So telangiectasia is basically red blood vessels around the eye. So we see that a lot in patients who have rosacea and ocular rosacea. But we
Hmm.
also see it in patients who have inflammation related to meibomian gland dysfunction. And basically, when we target those red blood vessels with the IPL, which is again, it's a laser, we reduce that telangiectasia and we reduce that inflammation. That indirectly reduces inflammation in the meibomian glands and allows the meibomian glands to function properly. Now, for those who don't know, the meibomian glands are producing oil, and oil is an essential part of the tear film that prevents the evaporation of the tears. So, if you reduce inflammation in the eyelids, then you're allowing that oil to flow freely and in a nice oily consistency, which prevents the evaporation of the tears.
And it's highly effective. And how long has it been around?
Oh, it's been around for a long time, I would say, but I don't know exactly when it was FDA approved, but I've had it for a year now, and I feel like I should have had it 8 years ago. So it's just something that has really, really revolutionized my practice, and I highly recommend it for those who are treating ocular surface disease.
Okay. Well, thanks a lot for sharing that. That's interesting. I wasn't all that informed on IPL. I didn't realize it was that significant and effective of a treatment. So moving on, one of the conditions that tools are really highly effective and specialize in critical care is keratoconus, which you have a background in. So how do you approach patients with keratoconus, and what point do you typically bring in a corneal surgeon for co-management?
So keratoconus is so much more common than we thought. We used to think it was like 1 in 2,000 people had it.
Hmm.
And now, there's obviously new studies being done with more specific testing like topography, more sensitive testing rather, like corneal topography, tomography, etc. And we're discovering it in so many more people. And we actually think it's probably closer to 1 in 300 or even
Oh,
more.
wow. That's
And so
significantly higher rate of incident. Wow.
yeah, so we don't have the exact prevalence, but we know it's a lot more than 1 in 2,000, which is what was quoted in previous studies. So since we're seeing keratoconus so much, the biggest thing we know is that the nature of the condition itself is to progress. So I was talking earlier about my specialty, which is vision rehabilitation. And I do that with glasses, but most often with specialty contact lenses like scleral lenses, hybrid lenses, rigid gas corneal lenses. So those are the devices I use to rehabilitate the vision. But as soon as the diagnosis is made, I really make sure that the patient has a referral to a cornea specialist that does corneal cross-linking. And the
Huh,
reason I
okay.
do is because I want to stop the progression. So I can't do anything to stop the progression in my office. And I know the nature of the condition is to progress. So I can immediately improve the vision with a specialty lens, but I definitely want them to have a referral and a relationship established with a cornea specialist that does corneal collagen cross-linking in order to stop progression.
Hmm, smart. And I'm sure you have a wealth of contacts and relationships in the corneal specialty. So I don't think there's shy of opportunities to refer those folks out to someone who's close and can take care of them.
Correct. Exactly. We're spoiled here. A lot of amazing corneal specialists in South Florida.
I'm sure you know quite a few at Bascom Palmer, seeing those were some of your old stomping grounds.
Exactly.
So I imagine the impact on those patients can be life changing for when you rehabilitate those patients with keratoconus. So without naming names, is there a patient story that stands out where your approach truly transformed their quality of life?
Absolutely. So I think, a patient comes in, they were told that, glasses can't really correct their vision, but they're not sure why. They come in, I talk to them, they're thinking they're going to need like a new pair of glasses, but then I do a corneal topography and, you can really see inferior steepening, the cornea. It looks like keratoconus. And then, educating the patient on what that is, showing them how well they can see. So the visual potential that they have with specialty lenses. And then again, establishing a referral with a cornea specialist. So just taking them from 0 to 100, right? 100 in terms of, You're getting them from a place where they really couldn't see, like they're barely driving, they're failing their driver's license test,
Hmm.
driving test or vision test, and they're coming in and now they can see 20/20, and you're setting them up with someone who can actually prevent the condition from progressing. So that alone is life-changing.
Well, I'm sure that, like you said, it happens a lot more often now than it has in the past because of better diagnostic tools. So, again, helping a lot of folks with that condition. Beyond individual patients, you're also working with some of the most complex cases. You often see people after LASIK complications, corneal transplants, or trauma. How do you approach those cases differently than more typical ocular surface disease patients?
So, everyone has a unique story. I don't think any patient has like um, a case where, again, don't have a formula in my practice, like, oh, this patient has this, so we're going to do that. It's talking to the patient, understanding their life, understanding what they do. Every case is so different. And so, with that mentality, you could really treat a patient that is just coming in for like reading glasses and a patient that has like severe Steven Johnson's or graft versus host disease or corneal transplant or LASIK. I think that there's a lot of different cases and each one is unique. Most patients also have concomitant ocular surface disease, so it's important to treat that in addition to trying to rehabilitate the vision as best as possible. And a lot of the time, if I can't do it, we have other resources like Miami Lighthouse for the blind and visually impaired. We've got, devices that they can use, vision therapists that are available as well for various other reasons. So, we're like again spoiled and there's no reason why we can't help all our patients, just trying to figure out what they need and where we can get them.
And as you're managing those cases, the technology around us keeps evolving. Of the emerging technologies in the OD space, which do you feel are meaningful and have staying power?
Wow, there's always new things coming out. It's really really interesting. And one thing maybe that sparked my interest was dynamic muscle stimulation, which is another device by Luminous, and it helps with the blinking. It helps strengthen the muscles in the eyelids, which is
Hmm.
really cool for patients who may have like eyelid issues, and also for aesthetic purposes. So obviously, getting more and more into aesthetics here, and then different products coming out as well, like different, eye care or makeup products that are like eye care approved that can really help as well mitigate a lot of the ocular surface issues that we see. Like I said, we have dry eye treatments in the pipeline. We have the recent launch of, two presbyopia drops. We've got a recent launch of, another eye drop for dry eye, the Acultramon. So we've got a lot of different things that are always coming out. And it's really, really exciting just to be in this space. Specifically for scleral lenses, we also have like wavefront guided scleral lenses, which
Hmm.
are kind of new and developing area in there, and so it's pretty exciting.
Well, good. I'm glad that again you're getting new resources, new tools, instruments to be able to again have like a whole catalog of solutions for different patients. Because as you said, one patient is just the one patient. They are going to be. If you line up 10 patients, every one will be diagnosed differently.
Absolutely, exactly.
So, and of course, the technology we can't ignore, you mentioned it earlier, is artificial intelligence. How do you see AI impacting the role of optometrists in the near future, and how are you preparing for practicing for it?
I think people are coming in with more knowledge, more education, which is not always a bad thing. Obviously, there's different platforms now that can be used to test vision and refract. So I think, again, just emphasizing the importance of specializing. I think a lot of the things that are basic in optometry are replaceable. And I think that a lot of the things that are more complex, like I was saying, just patient by patient care, case by case, you're not going to get that through chat GPT or AI. You're not going to get that through an app. You're not going to get a specialty contact lens through an app either. So I just think, I'm not worried about it. I do think that optometrists need to specialize though.
So, I mean, kind of along those same lines, thinking even further ahead, if we could look 10 years into the future, what do you envision the role of optometrists will look like by, say, 2035? And more, are they going to be more specialized, more collaborative, or something entirely new?
It's hard to say because every state is so different. And like I have colleagues in different states that are doing laser procedures. And that are doing more and more kind of interventional things that we really aren't doing here. So it's hard to say exactly on a, national, widespread national standpoint what optometrists are going to do. But I do see us being more and more collaborative with ophthalmology, working side by side, helping more, like I said, with the pre-post ops, helping more with more specialty care like ocular surface disease, aesthetics, and specialty contact lenses, and doing more of the complex things that tailoring things to patients so that patients can't replace us with things that they find online.
Good, good. And one area that could really shape the future is the ongoing conversation around laser privileges. Laser privileges for ODs are expanding in some states. Where do you see this trend heading and how will it affect the profession overall?
So I think that, it right now is limited to areas where there really aren't as many ophthalmologists. And I guess there's a need for optometrists to learn and specialize in it. I think, we didn't go through medical school. So there are certain aspects of doing procedures that I think need a medical background, but we do obviously have a lot of experience treating the eye, doing various treatments on the ocular surface. And I think that, as long as there's a need in certain areas, this will become more and more common in those areas. Whether it should be widespread is hard to say. It really depends. I think ophthalmologists here are doing a great job of attending to these patients and doing what they need to do. I think I've always seen optometry as vision rehabilitation, and I'm open to seeing what happens, but I don't have any training on lasers, and it's not something that I came into optometry thinking that I was going to do.
Well, certainly one of those topics that we're continuing to monitor and see where it goes, because I know there is a widely heated debate on both the pro and cons for that. And much like myself, we'll all sit and kind of see how that all plays out. So for the next generation of ODs who are listening, I'm sure they'd value your perspective. What advice would you give young optometrists or students about carving out a specialized path, much like you've done?
So I would recommend every optometrist get a residency. I know that's like unrealistic because not everyone can or wants to, but it really was such a valuable year in my training. I think I wouldn't be the optometrist I am today if it wasn't for my residency. Now, residency is optional for optometry, obviously. And so I highly recommend it. It gives about 7 to 8 years of experience in 1 year. And so I just think you really can't get that anywhere else. It really helps you build confidence as a doctor, helps you be exposed to more cases, and it really just establishes you when you leave that residency to be able to specialize in whatever it is that you have a passion for. And so I think, again, specialty is the future of optometry, and residency is the most direct path to get there. I think it is difficult, it is challenging, and it is something that, requires a lot of work and financial sacrifice, but I really recommend it for all.
So, with respect to these residencies, I mean, how frequent are they? How readily available are they? Is it just places like Bascom Palmer and Wills and some of these large institutions that have name recognition, or are they gonna? Do you think that the future holds more opportunities to have residencies available so that you can explore specialization as you have?
I think that, well, most of our residencies are actually with schools of optometry.
Okay.
Um, and so, there's many, many programs available. I think there's probably more and more available, but there's also more and more students. And not, like I said, not everyone wants to do it. And that's understandable. But I do think, there's a lot of opportunities for people to specialize if they want to.
Hmm.
So,
You've given great advice for the next generation of optometrists. And speaking of the future, another important shift where we're seeing across eye care is the growth of women in the profession. As vice president of the Women in Eye Care, you've been at the forefront of supporting that growth. How has the AT organization helped promote and advance the role of women in optometry, and what excites you most about the direction it's headed?
so I actually this year I'm the president, so that's
Oh,
exciting.
congratulations.
Thank you. And we are, what I love about that group is we're really uniting like all the eye care people. So we have optometry, ophthalmology, and industry. And everyone is welcome in the group. It's a group where we support each other, we elevate each other, and we push each other to succeed. And we provide, resources and meetings and a place where everyone involved in the eye care industry, again, whether it's ophthalmology, optometry, or industry, can feel welcome.
Well, I know again, I've been doing this quite a while here, and just from my vantage point, I've seen the percentage of women in eye care, just as a general category, have grown tremendously over the course of my 15 or so years in this industry, and it's good to see. I think that it's important that we have gender diversity in the space, because a large part of our patients are female, of course, and they want to be able to be treated. They want to see someone like them and treat them as well. So,
Uh-huh.
I think you guys are doing some really great work, and congratulations on being, I guess, it's an elected position, I'm assuming.
Yes.
And congratulations on being elected president.
Thank
So,
you.
Dr. Kramer, this has been such an insightful, inspiring conversation. Thanks for sharing your journey and your vision for where optometry is headed. And to our listeners, thank you for joining us on the Q-Switch Conversations. If you enjoyed today's episode with Dr. Kramer and want to keep the conversation going with her offline, she can be reached at her email at that's on you.
So on Instagram, Dr. Elise Kramer, and LinkedIn as well. And then my email is elise@miamicontactlens.com.
Well, fantastic. Thanks for that. Okay, folks, as always, we'd like to thank Riverside FM and Passionate Media for making this show happen, and of course, Meridian Medical for making it all possible. That's a wrap for this episode of the Q-Switch Conversations podcast. Until next time, I'm Spence, and I'm out.
You're listening to The Q Switch with your host, Spence.